Good morning, everyone. I am Dr. Saravana Kumari, Associate Professor from Department of Pathology from Lakshmanarayan Medical College. Today, I am going to take class about multiple myelomas. I will start with the lesson plan. I will proceed with introduction, followed by risk factors, pathogenesis, clinical features, lab diagnosis, and diagnostic criteria of multiple myeloma. Before going into topic proper of multiple myeloma it is a plasma cell neoplasm. So what is plasma cell? Where it is origin? So plasma cells are derived from the blood stem cells. These blood stem cells are differentiated into lymphoid stem cells, and lymphoid stem cells are again further differentiated into a lymphoblast, and it is further differentiated into B lymphocytes, T lymphocytes, and natural killer cells. If there is any antigenic stimulus, these B lymphocytes will be transformed into plasma cells, and these plasma cells will produce antibodies. And these antibodies produced will fight against the antigens and get rid of the antigens. So, any antigenic stimulus, there will be increase in the production of the plasma cells. This slide also tells you the same thing. So B lymphocytes, if there is any antigenic stimulus, the B lymphocytes will be converted into plasma cells and leads to the production of the antibodies. These antibodies will fight against the antigens. With this basic idea, we'll move on to the multiple myeloma. Multiple myeloma, it is a malignant multifocal plasma cell neoplasm of bone marrow. It is a malignant multifocal plasma cell neoplasm of bone marrow. It is associated with M protein in the serum and urine. So this picture will tell us about there is a plasma cells, and these plasma cells, generally the plasma cells will produce antibodies, and meager amount of M proteins will be produced. But in case of malignant plasma cells, and these malignant plasma cells, instead of producing the antibodies, it will produce more amount of M protein, and these M proteins will be detected in the serum and urine. So, hope you are convinced with the introduction. So, introduction, if it is asked, you should tell it is a malignant multifocal plasma cell neoplasm of bone marrow, and it is associated with the M protein in the serum and urine. And these multiple myeloma have a peak incidence of 5th to 6th decades, and it is rare under the age of 40 years, and it is more common in the males compared to the other females. It produces both osseous and as well as extra-osseous manifestations. Coming to the risk factors and pathogenesis, multiple myelomas, it has a genetic predispositions followed by exposure to the ionizing radiations, also responsible for the multiple myelomas. Chronic antigenic stimulations like HIV, chronic osteomyelitis, rheumatoid arthritis, even exposure to the chemicals like benzene, herbicides, and insecticides will be associated with the increased risk factors of multiple myelomas. Coming to the genetic predispositions, chromosomal translocations like translocation 11-14, translocation 4-14 are associated with the multiple myeloma. In addition, deletion of 13q, translocation of MYC genes, overexpression of MYC and RAS, which are growth promoting oncogenes, and mutation of P53 and retinoblastoma genes also responsible for the multiple myelomas. If the patient is having translocation of multiple MYC gene, it is associated with the aggressive diseases. So the patient will die soon because of the translocation of MYC gene. Coming to the clinical features, clinically it is an in onset is insidious in onset. This is slow in progresses. As I told previously, it usually affects 5th to 6th decade, that is 50 to 60 years, with a slightly male preponderance. It affects skeletal systems, immune system, and kidneys. Generally, morbidity and mortality is because of the renal failure and sepsis. So we'll see individually the effects in each organs. Skeletal systems. Because of the involvement of the skeleton, it will produce with the bony lytic lesions. So the reason for this lesions is the neoplastic plasma cells will produce NFKB ligands. This will activate osteoclast in the bone and this mediate the bony destructions. And because of this bony destructions, this patient can undergo pathological fractures. Sometimes they can have mild chronic pain, bony pain, and tenderness. If this lesion occurs in the vertebra, it may cause compression of the nerve root and it will cause severe nerve pain. So this picture you can see normally a bone marrow will produces the as I told you previously the lymphoblast will be differentiated to B lymphocyte, T lymphocytes and natural killer cells. The B lymphocytes where there is an antigenic stimulus it will be transformed into the plasma cells and produces the normal antibodies. This is the normal phenomenon. But in case of multiple myeloma, there is an increase in the neoplastic plasma cell proliferations. These plasma cell proliferations will produce rather than the normal antibodies, it will produce the M proteins. And these M proteins will produce the NF-κ beta and causes destruction of the bone. And this is the radiological image where you can able to see the destruction of the bone and this is called as osteolytic lesions. So the bony lesions will be seen multifocally. It can be seen in the vertebral column, ribs, skull, pelvis, femur, clavicle, and scapula. The lesions usually arises in the medullary cavity and erode the cancellous bone. This progressively destroyed the bony cortex. Now you can see this is the eroded lytic lesions. It starts with the cortex, then it starts with the medullary cavity and they erode the full till the cortex bones. So these eroded bones are prone for the pathological fractures and if mainly in the vertebral column and the femur. So this is the radiological image of the lytic lesions. You can able to see the punched out lytic lesions. It's the typical feature of the multiple myelomas. So far we have done with the effects of neoplastic plasma cell proliferation in multiple myelomas and its effect in the bone that is responsible for the lytic lesions. Now we will move on to the effects on the humoral immunities. As I discussed prior, a bone marrow, the normal plasma cells in response to the antigenic stimulus, it will produce the antibodies. So this is the process. The normal plasma cells will produce the antibodies and mild amount of M proteins. But neoplastic plasma cells will produce more number of M proteins compared to that of the normal plasma cells. Because of this, the defect is in the plasma cells and it will compromise the function of the B cells. So because of that, there is a elevated M proteins and these M proteins will cause us the depressed functional of antibodies and this leads to the increased risk of bacterial infections and the patient with the multiple myelomas will prone for the pneumonia and pyelonephritis. This patient also will have granulocytic dysfunctions and neutropenias. So coming to the renal dysfunctions. Multiple myeloma patients have a renal dysfunction is mainly because of the light chain deposition in the glomerulus and the interstitiums. Not only that, there is a obstructive proteinaceous cast. This proteinaceous cast composed of Benjon's proteins, Tom proteins, and albumin in the distal converted tubules and the collecting duct. In addition, the destructive bony lesions will have the liberation of the calcium in the serum, and this leads to the hypercalcemia. This hypercalcemia patient, the patient can have the increase in the serum calcium level and leads to the dehydration and formation of the renal stones, and this patient can have frequent bouts of bacterial pyelonephritis and hypogammaglobulinemias. And 25% of the patients with multiple myeloma can have the renal failures, and this patient also will have hypercalcemias, glomerular deposits of amyloids, hyperuricemias, and the patient can also have a myeloma cells infiltrating in the kidneys. This contributes to the renal failure. And multiple myeloma patients can have increase in the bleeding tendencies. And this patient can have thrombocytopenias and dereached platelet functions will be there. And in addition, with this bleeding tendencies because of the M components, that is the M proteins, will interact with the coagulation factors and leads to the coagulation abnormalities. Multiple myeloma patient, because of the M proteins, they can also present with hyperviscosity syndromes. This hyperviscosity is mainly because of the hyperglobulinemias, and it produces headache, fatigue, visual disturbances, and hemorrhage. So coming to the laboratory findings, this multiple myeloma patients can have, we can have the investigations like blood investigations followed by bone marrow, biochemical abnormalities, and electrophoretic studies. So in the blood, 50% of the patient there will be some of the atypical plasma cells will be seen in the patients, and anemia will be noticed. That too, normocytic normochromic anemia will be seen in the 80% of the patients, and hemoglobin will be decreased, and the decreased range will be 6 to 10 grams per TL. This patient also will have a rouleau formations, and this rouleau formation is because of the hyperviscosity of the blood. This patient with multiple myeloma can have elevated ESR, and bleeding times also will be increased. So, coming to the peripheral smears, RBCs can shows normocytic normochromic anemias, and RBCs we can also notice rouleau formation, and there will be some bluish background will be noticed because of the increase in the immunoglobulins. WBCs are usually normal, platelets will be normal or increased. These are the peripheral smear findings. So you can notice here there is a rouleau formation. So rouleau formation is the RBCs are packed like a stack of coins. You can see this, and background you can see some bluish background because of the increase in the immunoglobulins. So this rouleau formation is because of the M proteins. So coming to the bone marrow, there is a usually bone marrow when it is reported, usually we should report like a cellularity, whether it is a hypercellular or hypocellular or it is a normal cellularities. And then we have to comment about the hematopoiesis, how this erythropoiesis, myelopoiesis, megakaryopoiesis, any abnormal cell is there or not. Now we should report the bone marrows. With this basic idea about bone marrow, will come to the bone marrow findings in the multiple myeloma. Cellularity wise, there will be in hypercellularity, and this marrow will be replaced by the tumor cells. And this phenomenon is called as the myeloptosis, and there will be an inhibition of the hematopoiesis. Myeloma cells constitute about more than 10% of the marrow cellularities, And myeloma cells usually will be seen as clumps or in a sheets or scattered among the normal hematopoietic cells. Erythropoiesis are usually due to the normal plastic maturations because of the increase in the plasma cells. It is usually diminished, and because of that, this patient is having anemia. Myelopoiesis will be normal. Melanocardiopiesis also will be normal, but it will be decreased. So this picture you can able to see there is the RBCs and you can see the plasma cells. So everywhere there is a plasma cells are increased. And so next we see the morphology of the malignant plasma cell. Usually it will resemble the normal plasma cells to sometimes it can be seen as a large immature cells, even it can be seen as a undifferentiated cells. These cells can be binucleated or multinucleated. Usually, the plasma cells nucleus will be eccentrically placed, and you can be able to notice the nucleoli. And the cytoplasm of the plasma cells will be abundant, and it is a basophilic with the perinuclear core, and vacuolizations also will be noticed. And there will be Russell bodies also noted. Russell bodies are nothing but it is a iron globules which is composed of only immunoglobulins. So you can able to see this plasma cells, both binucleated, multinucleated, and eccentrically placed, and some of the cells which is the presence of the immunoglobulins is also noted in the plasma cells. So coming to the biochemical parameters, there is a destruction of the bone and leads to the release of calcium in the serum. So this patient can have hypercalcemia. And because of the necrosis of the tumor mass of the renal failure, the patient can have hyperuricemias, and even there is an increase in the serum beta 2 microglobulins and other globulins in the urine and the serum. These are the major biochemical abnormalities. An increase in the serum beta 2 microglobulins, which is the prognostic markers, if increase in the serum beta 2 microglobulins, it leads to this patient has a poor prognosis. Right? Renal function compromised, and this patient not only increase in the urea, the result increase in the serum creatinine and uric acid levels will be increased. And in the advanced stage of the multiple myelomas, the serum albumin also will be reduced. Coming to the electrophoretic studies, in the blood there will be raised in the monoclonal immunoglobulins with IgG most commonly, IgG will be most commonly seen, followed by IgE, IgA, IgE types. And urine will be a light chains or Benjon's proteins. 60 to 80% of the cases with multiple myelomas can have the Benjon's protein. It can be either a kappa or lambda type of the light chains. So this is an electrophoresis image. You can see there is an increase in the M proteins. That is a increase in the spike, monoclonal spike of M proteins. It will be seen in 80 to 90% of the cases of multiple myelomas. So far, we have done with the laboratory diagnosis. Next, we will see the morphology of individually each organs which is involved in the multiple myelomas. In the bone, as I discussed, because of the destructions of the neoplastic plasma cells, the patient can have punched out lighting lesions, most commonly in the it's a multifocal involvement, most commonly in the ribs, vertebra, femur, and renal involvement. Because of the renal involvement, this patient can have myeloma kidneys. Myeloma kidney is nothing but there is a light chain cast of Benjon's proteins deposited in the renal tubules and damage the renal tubules. Some of the patients can have amyloid deposits, that too amyloid light chain type, and this is the patient with the amyloid deposits that leads to the nephrotic syndrome. And due to the hypercalcemia, this patient can prone for the nephrocalcinosis. and these patients can present with acute and the chronic pyelonephritis and finally end up with the renal failures. So this is the image normal bone which is involved by the multiple myelomas. So this the lesion will be the normal bone will be replaced by the soft gelatinous red gray tumors. You can see this picture, soft gelatinous red gray tumors, and this affected bone can show focal or diffuse osteoporosis in the radiology and responsible for the light lesions. And this not only involvement of the kidney bone, there will be the myeloma cells infiltrate the neurons also, that is the infiltrated the nerve trunk root, and it will produce the non-specific polyneuropathy. If this amyloid deposits seen in 10% of the cases of the multiple myeloma, and the amyloid will be, as I discussed prior, it is the amyloid light chain type, and the amyloid deposits will be seen in the multiple organs. And this is the special strains where Congo red stains, and the amyloids are highlighted as the red pink in the glomerulus and the tubules. And this is the amyloid deposits in the skin, the subcutaneous, and this is the special stain apple green birefringence stain which gives positive for the amyloids. And not only in the nerve root, it also involves amyloid deposits in the liver, spleen, and leads to the hepatomegaly and the splenomegaly. And sometimes this poem syndrome also will be noted in 1% of the cases of the multiple myeloma. The poem P for polyneuropathy, O for organomegaly, E for endocrinopathy, M for multiple myeloma and skin changes. Coming to the diagnostic multiple myelomas that will be in the marrow, plasma cells will be noted, that is more than 10% plasma cells, and radiologically there will be a lytic lesion and demonstration of the M proteins in the serum and urine. According to the criteria, the major criteria and minor criteria is there for the diagnosis of the multiple myelomas. Major criteria, there is an increase in the plasma, bone marrow plasma cells more than 30%, and the serum immunoglobulins IgG more than 3.5 or IgA more than 2 grams, urinary kappa or lambda change more than 1 gram per 24 hours, biopsy proven plasmacytomas. This is the major criteria for the multiple myelomas. And the minor criteria will be plasma cells in the bone marrow will be 10 to 30%, monoclonal proteins present, but it is only less, decreased normal immunoglobulin levels, and lytic lesions. So, so these are some of the diagnostic criteria for the multiple myelomas. Uh, so our take-home message will be plasma cell neoplasm. It is the neoplastic plasma cell proliferation, and it produces lytic lesion in the bone and renal dysfunctions that's a compromised in the compromised in this humoral immunity, and diagnosis by the increase in the plasma cells and lytic lesions and demonstration of the M proteins. And radiologically, it is the presence of the punched out lytic lesions in the bone. And electrophoresis, there is the increase in the M proteins. And peripheral smears, there is the rouleau formations. And marrow plasma cells will be increased. So hope you understand multiple myeloma, and any doubts you can contact me. So next class we will speak about NHL. Thank you.